So the foundations of gait and balance begin in the first years of life. To learn foundational principles of gait, the most common human functional movement, I want you guys to stick with us. I'm honored to introduce to you our next guest presenter. Dr. Martin Rosen, with 38 years of clinical and teaching experience, has taught pediatrics, craniopathy, SOT, and practice management internationally to thousands of chiropractors and chiropractic students. While lecturing and teaching, he's compiled hundreds of hours of presentations on technique and research, evidence-based protocols, and his unique approach to pediatric care is evidenced in his published books, videos, and professional articles. Today, he'll be teaching us the foundations of gait and balance for the first 2 years of life. Dr. Marty, thank you so much for being here. We're excited to learn from you today.
Thanks, Krista. It's great to be here again. I'm excited. It's a nice forum, and it's great that you have so many people out there. It's, especially during this time, this is one way we can get out and share what we know and kind of connect again, because that's what we really need right now is some connection, I think.
Absolutely. Well, without further ado, I'm going to give you the floor. And if anybody has any questions as we're going, feel free to type those in the chat, and we'll have a couple minutes at the end to ask more questions to Dr. Rosen.
Sounds
Go ahead
good.
and take it away. Thank you.
All right. So I want to talk a little bit about the foundation years, and I want to just give you an idea. What we're talking about when we talk about gait is we're talking about a pattern that develops using a bunch of biomechanical features, including the entire central nervous system. And again, it's based on our ability to use, develop, and conserve energy. Any abnormality in gaits and the neuromuscular system can release us, or can create a pattern of anomaly, increased energy and decreased energy function. So what we're really talking about here is a system that does not stand alone. The gait system, the vestibular system are very intricately related. And the reason for that is because the ventricular system is that sensory system that is responsible for providing our brain with the information we need to create motion. Head posture, spatial orientation, it is involved in all our motor function. So these two things not only do develop at the same time, but they have to work in coordination, because if they do not work in coordination, then not only gait anomalies occur, but actually functional development in our nervous system occurs. So things like the vestibular system deal with posture and the vestibular sense. They have postural control, which deals with all the small muscle and body. They deal with muscle tone, where you talk a lot about in chiropractic about abnormal muscle tone, hypo or hypertone, not only kinesiologically in the spine, but actually in the home when dealing with infants. Again, that's a big thing. We're talking about infants. We talk about high or low tone in the central nervous system. And this is when that system develops. So when you think about the vestibular system and you think about the gait system, you have to think about balance. You have to think about postural control. You have to think about muscle tone. You have to think about spatial orientation. And then the two other things, or a lot of other things that we have to talk about alertness and cognitive ability, as well as eye movements and our ability to function in our environment and to learn. So the vestibular system, which develops in early childhood, is actually responsible for our alertness and focus. I talked a little bit a minute ago about how the entire nervous system is called into effect. Well, what happens is we are delineating our nervous system a certain amount of energy just to maintain ourselves in gravitational forces. And that's up to 80 to 90% of our actual neurological function is to walk, talk, to move around, to keep our body in motion, and keep it balanced. There's about a 10 to 20% less left of that nervous system for, let's say, higher functional capabilities, right? Both mental and physical, and also for healing. Okay, we're maintaining a homeostatic environment with 80 to 90% of our nervous system. There's only that smaller portion that's left for the healing and the environmental process. And that is also dependent on how much of our postural, musculoskeletal nervous system is needed to basically keep ourselves in balance. So the more compensatory patterns we develop, the more compensations. The only place our nervous system can pull from to support that is from that piece that's left over for those higher centers of learning. So that can create a lot of dysfunction and a lot of difficulty, a lot of stress, and a whole myriad of stressful situations and a whole myriad of disease process. So we get different types of issues when we deal with this vestibular system. So things like balance and postural control, they're essential for all our motor skills, gross motor skills, and eventually fine motor skills. So what we have is children, often and adults who are more sensitive to movement, may avoid activities that reduce their opportunities for learning. They decrease stimulation to the nervous system. And the first 2 years of life, stimulation to the nervous system is its lifeblood. That's when we form the most synapses. So those who seek out extra input are often too quick and have poor control over their movements. We call them clumsy, and they get into trouble because they're constantly on the go. They're hyperactive. We have those diagnosed ADHD or whatever you want to put on the spectrum. These are kids, are often people who basically their posture and balance control is affected. They can't basically work it as well as possible. It takes too much energy to avoid these activities, and that decreases the way their nervous system functions. They usually have slower responses, often have poor coordination, and tire more easily as they need more effort to sustain the same thing as their peers. It's very simple. Kids with ADD or ADHD sometimes have to struggle twice as hard to keep up or to take in the same information as someone else. So what happens is their system fails, it breaks down, and therefore they slow down, and then they have to kick it back up, and it takes all this energy. So it's a constant up and down of energy movement. Also, the vestibular system is responsible for spatial awareness. Okay, that is your ability to move around in space. Okay, it is important for subjects like math and essential things for like timetable. So that is your spatial ability also affects your cognitive ability. It plays a role in making sure that you get your letters and numbers facing the right way. Okay, simple things like that. Eye movements, visual proprioceptive writing reflex. As soon as you can hold your head up, the visual proprioceptive writing reflex kicks in. And that is responsible for your ability to not only focus on points close to your convergence, but also to scan right and left, to be able to track, to catch a ball, okay, to keep focused. It's also, again, if you can't track or you have an inability to converge, it's much higher and it takes much more energy for you to focus and to stay focused. So what I'm trying to point out, and I know what Krista talks about a lot when we all talk about it, posture is not just posture. There's nothing in your body and your nervous system that stands in isolation. So the development of a positive gait and vestibular balance mechanism is going to affect you for the rest of your life. Why? Because these systems form in about the first 2 years of life. And what I mean by it is that the foundation is formed in those first 2 years. The period from birth to age 2 is probably the most dynamic and important phase of postnatal development and brain development in human beings. It suggests that this period of time creates a structural underpinning of cognitive and motor development in early childhood, as well as the potential, and this is important, pathogenesis of neurodevelopmental disorders. So this foundation, if it's aberrant in its beginning, sets up a much easier time frame or a much susceptible, more nervous system to neurodevelopmental disorders later on. Think about this. In the first 2 years of life, the brain reaches 80 to 90% of its adult volume. Okay, synaptic development is going at about 1,000 to 100,000 synapses occurring to each neuron in this period of time, and the overall gray matter reaches a maximum. That means the amount of actual matter, gray matter, reaches a maximum about age 2. And myelination, which is, of course, we know, chiropractors are pathways. Basically, after birth, by the first 2 years are about 90% laid down. So we are laying down an incredible foundation. The actual synaptic growth pattern, the peak of your synaptic development, your body to create neuroplastic patterns and create pathways, actually peaks at 8 months of age. So think about that. The first 8 months of life, you are laying down a foundation that you're going to be living with probably for the rest of your life. And to add to that foundation is going to take an enormous amount of energy and development. So the pattern of adult myelination is present by the end of the second year. So the roadways, the synapses, the gray matter, all this is happening in those first 2 years of life. That's why it is so important to have all the factors at their optimum potential at this point. It is a pressing clinical need that we check children at risk for neurodevelopmental issues or disorders within that first year of life. That's what our role is. That is the time when we can really make the biggest impact. Not that we don't make impact throughout the rest of lives and can't change it, but the work is so much harder. Think about this. The cerebellum, which is your mainframe computer, that's where all the information is going to process, where all your gross motor movements are coming, where all basically the information is going to be processed and started. The visual cortex is down there. All that is happening in the first year of life. It grows 240%. That's huge. That's 240%. And we all know the brainstem, cerebellum, spinal cord, upper cervical spine are intimately related. The most vulnerable area in the pediatric patient during the birth process and the first 2 years of life, the cervical spine, upper cervical spine. The balance mechanism there, all the rotation is there. So that is the area that we have to look at. That area directly reflects into one other area, which I always like to talk about as one of my specialties as a craniopath, is the sphenobasal symphysis, or the cranial base. The sphenobasal symphysis, and I'll pull a little skull here. I know it's going to be a little picture here, but the sphenobasal symphysis is this purple and yellow area. And what is so important about this area, it is a synchondrosis joint, okay? It is the most freely movable joint in the cranium. It controls the tension in the dural meningeal system. It also does not fuse until age 26. It articulates with every single cranial bone except for the nasal and lacrimal bone. It is responsible for motion of cerebrospinal fluid. It is responsible for motion of dural tension, and it is responsible for the phylogenetic development of a lot of the craniofacial structures. So it touches with the vertebral column, with the mandible, provides conduits for all the vital neural and circulatory connections between the brain, face, and neck, houses and connects the sense organs in the skull, and forms the roof of the nasopharynx. So it's a pretty important structure. And it is mitigated, and its motion is determined by amount of what we call dural tension, how much dural tension is throughout the entire spine. And that dural tension is mitigated by postural mechanics. Too tight or too loose. The dura attaches from the filum terminale up into the second sacral well, along the entire vertebral column, and every single nerve root that exits the dural port is attached to the dural meningeal system, very strongly into the base of the skull, and then up into the cranium to form the dural meningeal system, the falx and the tentorium, and then in infants, actually out through the sutures of the skull around the periosteum and the cranium. So if that's too loose or too tight, it is going to affect postural mechanics. And the reason it's going to do that, it's going to affect the development of the secondary curves. We have our primary curve, which is the curve that we're born with. We come out, and that is our basic curve. As we start to lift our head up, we form the first secondary curve in the cervical spine. And then as we start to sit, eventually crawl and walk, we start to form the second secondary curve in the lumbar spine. If the underlying structure, the underlying tissue is too tight or too loose, that will affect the mechanics of that system. And what's even more important, or as important, is that system forms osteoclastic and osteoblastic activity in relationship to gravitational forces. What I mean by that is if you change gravitational stresses, if you have a bad right knee and you lean to the right side, you do that for 2 years, you're going to have bone remodeling in that particular direction. So bone remodeling occurs from two factors: gravitational stresses and what we call a piezoelectric effect. For example, in a scoliosis, if there are compressive forces on the side of compression, there is a much stronger positive charge around the vertebral bodies in that area. On the side of concavity, there is much greater negative charge. And what that means is that can affect calcium deposition, because as we know, calcium is a positive ion, will be repelled from the positive side and attracted to the negative side. So that will actually cause the bone to remodel in a negative, or under correct care, if we change the biomechanics into a more positive way. So the piezoelectric effect, the electromagnetic effect, not only affects osteoclastic to osteoblastic activity, but it also affects nerve transmission, because nerve transmission is electrical conduit as well. And if we change electromagnetic fields around that nerve, we change the way that nerve works. So the dural meningeal system has one other really important factor that's also mitigated by posture. It changes, affects the angles between the sphenobasal and the lumbosacral angle. So a normal 30-degree lumbosacral angle helps pump cerebrospinal fluid and keeps the sacral well, which is located in the base of the sacrum. So the sacral well is basically this area back in through here, where there is the dural meningeal system and the cerebrospinal fluid. That sacral well holds a certain amount of cerebrospinal fluid. And as we walk, as we ambulate, and the sacrum creates a nutational motion, it pumps fluid from that sacral well up into the cranium, and then that sphenobasal mechanism affects the tension on the ventricles, third and fourth ventricle, and it pumps fluid down. So we have a system that does this: pumps fluid up, pumps fluid down, like this. And that is mitigated by respiratory mechanics and transverse fascial planes. which is part of what we do when we make adjustments. When we change the pelvic balance, we work on changing that balance. We change the transverse fascial plane of the pelvic. One of the big things that happens with chiropractic is when we make adjustments and we change tension in the thoracic spine, we change tension on the diaphragm, which is one of our largest transverse fascial planes, which also attaches to the psoas muscle from the crew of the diaphragm, which attaches to the pelvis, which is a hip flexor. So again, I guess the point I try to make about this is that there is nothing that comes in isolation when we do with what we're dealing with. The tension created, or the dynamic tension, is present in the function of the neural tissues, the fascial system, and the musculoskeletal system. This is all mitigated by what we do. Changes in these angles, changes in the lumbosacral angles, we all know if the lumbosacral gets smaller, that decreases the lumbosacral curve. That decreases the lordotic curve in the lumbar spine. If the lumbosacral angle is too large, it increases it and creates a hyperlordotic curve. Well, the same thing happens in the cranium. If the spheno-basal angle gets too tight, it pulls on the dura, straightens the dura, and can change the curves in the spine. So it can actually straighten the spine. Every time you breathe in, ideally, what happens is your spinous process will go inferior, your spine will slightly straighten. When you breathe out, the system relaxes, the curves start to come back to normal. If the dural meningeal system or the respiratory system is inhibited by fascial stresses, that inhibits that normal motion. So literally the spine is not flexing and extending like it should. You lose mobility in that spine. And once you lose mobility, you lose function. And once you lose function, obviously we know that affects the nervous system, musculoskeletal system, and the entire system is under stress. I want to talk a little bit about the sacrum just for a second and why it's so important in those first 2 years of life. Before you start to walk, before you start to ambulate, the posterior aspect of the sacroiliac joint, which is back here, which is held together by ligaments, is not functioning very strongly. It is not a weight-bearing joint. The spine, the central nervous system, the cranium in the first 2 years of life, its pliability is really set up so that the nervous system can develop. So it gives it space to grow, literally. The anterior part of the sacrum, the front part, is called the sacral boot. And that is a synovial joint. And its whole purpose is to create motion. It's where sacral nutation occurs. The back part of the sacroiliac joint is the weight-bearing part of the joint. So while you're dealing with a preambulatory infant, what they're really doing is setting up a paradigm by which the anterior sacral boot mechanism is creating balance motion. So, for example, you see a little kid that crawls with one hip up in the air, right? You've seen that, right? You see a little kid who doesn't crawl. If they're not crawling and creeping, they're not moving the sacroiliac joint. They're not creating not only neurological cross patterns, but they're not exercising the sacroiliac joint, creating balance nutation. So when that child starts to stand, they actually already starting to compensate. And when that compensation occurs, then they start to affect the growth and the strength of the posterior weight-bearing aspect of the spine. And you change posterior aspect weight bearing, you can change complete head posture and biomechanics. The proprioceptive system in the pelvis is aligned with the proprioceptive in the transverse fascial plane of the cervical spine and the temporal mandibular joint. Basically, the job of your spine is to hold your head over your tailbone. Right, that's it. That's one of the things. You want your head over your tailbone. You don't want a forward head posture. You don't want a back head posture. If the sacroiliac joint doesn't form right and the weight-bearing mechanism is imbalanced and you can't bear weight posteriorly into that joint, what's the first thing the body's going to do? It's going to throw the head forward. And once we have that forward head posture, that's going to affect everything, including the jaw mechanics. All right. So kids, when we talk about kids with tongue tie or nursing issues, if the biomechanics of the temporal mandibular joint is off, let's say the mandible is pulled back. As the mandible pulls back, it affects the temporalis, the SEM, and that can actually straighten the curve of the cervical spine as well. So the entire balance of the cranium, the entire balance of the pelvis have to work together. There are reciprocal motions between the sacrum, second cervical vertebrae, and the occiput. They're supposed to move in coordination with each other. If that is not the case, then you're going to have a dysfunctional system and it'll create compensatory patterns. And as we know, the problem with these compensatory patterns and that create adaptive changes become set in stone. And if they're not corrected in those first 2 years of life, what you're going to have is a person who's going to deal with a compensatory spine and nervous system literally for the rest of their life. The cutting off point that we look at when we're talking about motor functions is somewhere around 12 to 17 months. By that point in time, if you have a child that's not walking with their arms in a primary balance mode, can't use two words spontaneously and meaningfully, and they don't have cortical opposition in each hand, in other words, you have high-hand coordination. If they haven't formed that by 2 years of age, that by the time they're 6, when the central nervous system is set, basically you are who you are at 6, you are today nervous system wise, they're going to have compensatory changes from that period of time, and they're going to have a more difficult time adapting. Or even if they don't have a difficult time adapting and we don't notice it, I can guarantee you that they have lost some of their optimum potential, which is what chiropractic is based on, is restoring optimum potential. Now, we may not know this. It doesn't mean that they can't be great athletes or mathematicians or brilliant, but we know, just like Dr. Sperry taught, is that we start to pull from that higher level of function. We start to take from those reserves. We're going to decrease the amount of reserves available, and it's going to change optimal function. So one of the indicators that we look at when we evaluate kids is primary reflexes. Primary reflexes have two, as far as I'm concerned, two main functions. One is a protective mechanism, fight or flight response, like the Moro response. That's why they're developed, to protect ourselves. The other is to help to develop the underlying nervous system. And the reason, if you have a child or an adult with a retained primary reflex, what that is telling you is that their nervous system wasn't able to develop all the way through correctly. Once the prefrontal cortex kicks in and is really established, like age 3 or 4, there's no need for these primary reflexes. We already have, so for things like a Babinski response, which should be gone by 2 years. Once we have a normal gait, matter of fact, not only don't we need a Babinski response, but a Babinski response would inhibit a normal gait, because every time we hit the front of our foot, our toes would flare up, ideally. Other things like a Moro reflex, that's a fight or flight reflex. We don't want that to stay, because that means you're in a fight or flight state for the rest of your life. So autonomic neck reflexes, visual proprioceptive writing reflex, especially the visual proprioceptive writing reflex, that's a growth stimulated reflex. If you don't maintain a visual proprioceptive writing reflex, that literally when you turn your head, if your eyes don't track it and you try and take a step, you're going to fall on your face. So the primary reflexes are there to create two things, protection and development. If they maintain or last past that age 2, which is when the last reflex of Babinski is gone, then you know you have a compensatory nervous system and you have some issues that you're dealing with. So the first 2 months of life stimulate that visual cortex. From 4 to 6 months, as the kids begin to crawl, posture reflexes begin to play an important role. So the reflex areas move on. As infants begin to crawl, they need visual feedback, okay? But it is reduced because now they've developed that visual cortex to a certain point, and now they're creating cross patternings. And at certain stages of upright postural progression is characterized by periods of reliance on the visual system as a primary mechanism. So each time you take that next step, so once you get into that crawling, you decrease your visual feedback necessity. Once you stand up, it has to increase again. So there are pre-programmed proprioceptive feedback loops based on the brainstem that are supposed to fire off at specific times as you develop normally. If those do not fire or are inhibited, and when we talked about the cerebellum, those reflexes are not going to fire off correctly, and you're going to get compensations. You'll see kids that parents say, oh, he went from sitting to walking, he never crawled. That's not a good thing. That's a misstep. Have kids who walk with balance motion, like this with their arms out, they're 20, 22 months old, and they're still walking like they're walking on a tightrope. That is an issue. That is a problem that we're dealing. So progressing from crawling to sitting upright to standing to reflex head control is a primary factor necessary for upright postural control. All those reflexes, all those neurological sequences of the postural development is, listen to this, is predicated on mastering reflex control of the head posture relative to gravity, so the trunk and lower extremity control can be learned using a fixed reference point. That means that your proprioceptive system in your pelvis, the sacral nutation ability, and the position that it holds your head all have to be in line for you to develop basically a good postural control system. And the literal backbone of this whole system is also the spine. Anytime we change that postural mechanics, for example, with the forward head posture, that not only does it put a disadvantage on the musculature because it puts tension on the muscular, but it stretches the dural meningeal system, reduces blood supply and cerebrospinal fluid into that area. So we need to follow through these processes and make sure that the child not only is functioning normally, but going through these developmental processes in the correct way. Remember, the nerve impulse, as it passes through, goes through that course, the nerve impulse has to be at a set speed and a set intensity as well. Too little or too much afferent impulse into a muscle causes that muscle to what? To spasm, to tighten. Too little causes that muscle to be hypotonic. So these reflexes and the ability of the body to transmit impulses and the tension of the dermomeningeal system and the piezoelectric effect that can be affected by postural mechanics all play a role. Think of this. This is your first year of life. In the first year of life, you develop 1,000 to 100,000 synapses per neuron. Your brain grows 2.5 to 3 times its birth side, and the total brain volume increases 101% in the first year, with only 15% in the second year. Your cerebellum, as we said before, grows 240%. By age 2, 80 to 90% of the adult volume of gray matter is there. And also by age 2, 90% of the myelin sheaths are laid down. By age 6, you've created 90% of your motor and sensory integration. All right, so this is all predicated on those first 2 years of life. So if this system isn't working, what can you expect? Well, if the system isn't working, and just think of where you could put this into the alphabet soup of neurodevelopmental disorders that we have set up in the parameter in our country, around the world these days. So if some children and adults are sensitive to vestibular input, they mean the brain responds only to a small amount of movement. Other children, they are slower to respond to the input, which means they need more movement to understand the information. So again, the difference between proprioceptive disorder, propriointegrative disorder is those two things. And also children and adults can also respond by seeking out more movement or just being slow to respond and a bit sluggish. So these adults may display some type of physical activity or emotional activity that constantly stimulates the system. They're not getting enough input, so they stimulate itself. This is the entire Asperger's system that we're looking at, or this higher neurodevelopmental, bandwidth that we're talking about. For example, kids who have sensitivity input, they'll avoid playing on swings, slides. They'll seem afraid of elevators. They'll avoid having their head tipped back. They'll be uncomfortable when you wash your hair. They get travel or motion sickness easily, okay? Kids who are seeking out vestibular input, they want more input, so they pursue movement. They can't sit still. They rock in a chair. They love extreme fast-moving input. They like to spin. They won't get dizzy. They can spin and spin and spin, and they won't get dizzy. You'll get dizzy watching them. Kids who are slow respond to that activity, they'll bump into things. They become uncoordinated. They fall over objects. They lose their balance. They have very poor muscle tone. They're lethargic all the time. I mean, this is about the vestibular system. This is about neurodevelopmental disorders. So to sum things up a little bit, what I like to say is postural patterns and baseline functional parameters become set by age 2. The greatest synaptic development is around 8 months. Full integration at around age 6. Uncorrected neurological patterns become primary source of stimulus through life. Compensatory patterns lower the adaptive thresholds and often build on each other. Early issues with the temporomandibular joint, nursing, latching, etc., put stress on C1 and C2, and they cause recurring subluxation patterns, muscle splinting, and imbalance issues there. The balance between the sacroiliac joint, sacral movement, cervical spine, and cranial mechanics develop their neurological and structural foundation in the first 18 months to 2 years of life. And of course, as we know in chiropractic, and we should know everywhere else in every other healthcare profession, the earlier the detection and correction is the best approach, not the model of patch it up and repair. That's all I got for today.
Amazing. Dr. Marty Rosen. Okay, in the chat, let me know if you learned something. I see you guys clapping. If you're anything like me, you were over here writing down tons of notes. You know, we had the opportunity of learning from Dr. Rosen last year on the Chiropractic Pediatrics Virtual Summit. Learned so much. I said we have to get him back again this year for Peds Week. So thank you so much for being with us.
My pleasure. I love it.
And if you have time, I'd like to ask a couple of questions. There's some really good stuff posted in the chat here. So the first question that we want to ask is, in infants, do you mobilize the sphenobasalar junction via the palate? How do you
Yes.
recommend mobilization?
Well, there's two ways to do it. So depending on your particular skill set or desire, you can mobilize the sphenical basilar from the external correction, but I tend to do internally more. It's a little bit more intense. It's a little more powerful, but you can also get to both sphenoid wings as well as the sphenical basilar through the palate as well as externally. So yes.
Nice. And when it comes to SI joint formation, how do you foster good SI joint formation?
Basically, by making sure there's normal sacral nutation, working with anterior inferior sacrums. I very rarely, because of the chance of driving a sacrum anterior, adjust an ilium in an infant. I most often adjust the sacrum to the ilium as opposed to, and I feel that that helps put less stress on the posterior weight-bearing joint. So until they're ambulatory, I very rarely adjust the iliums. I tend to use the sacrum as the lever system to make the correction.
Nice. And for infants that aren't crawling, how do you teach parents to encourage them to crawl at home?
Well, so one thing is to get on the floor and play with them. Another thing, if it's really bad, is you can make a crawling track. And what a crawling track is, you take about a 6-foot piece of board and you put little barriers on the side, and you hold it up a minimum of 18 inches to 2 feet and put the child on top and have them kind of try and crawl down it. It makes it easier if they're crawling in a downhill motion, and we call that a crawling crack. Sometimes if you pat it, you can actually leave them and let them hang on it 18 inches, not leave like the room, but leave them to hang on it, and that will help teach them to crawl. The other thing, if it's really bad and the child can't cross pattern, two things: you can have parents help them by putting the child on the belly, and then having the parent literally cross padding them by lifting one leg and one arm, and then one leg, the other parent do this. Do that. And the last thing is swimming. If you get them in a pool, that will help them cross pattern.
Nice. Love those recommendations. So easy to implement and so powerful.
Right.
And May asks, toe walking after age 5, how would you suggest fixing it? And is this a vestibular issue?
Yes, it's actually more of a balance issue. Almost always, in my experience, toe walking is a relationship to the occipital condyles. They're either posterior or anterior, sometimes both, sometimes one unilaterally, and the position of the occiput will change the flexion extension of the neck. It also, because of the visual cortex, changes the way their eyes track. So if you watch toe walkers, very often toe walkers may be somebody as they're picking up that when they actually look, their eyes, when they look straight, their eyes are actually slightly pointed down or up. So in other words, part of the toe walking is their desire to get their eyes directly straight with the horizon. So you need to look at their eyes, look at their tracking ability, convergence ability, and the position of the occiput in relation to the atlas condyles. Those are the biggest things with toe walking. The problem with children over 5 who are really bad toe walkers, and if they've done it for a long time, is you have to make sure that they haven't shortened their Achilles and made it more difficult. So sometimes you have to actually, if I have a kid that age doing it, I actually may give the parents at the same time adjusting that. The other thing is the occiput. You have to look at the sacrum for anteriority of the sacrum. Give them exercises to help stretch gastrocnemius and soleus so that they actually are not uncomfortable when their foot starts to lower. It's like if you wear high heels all your life and then all of a sudden go to flat shoes, it can be a problem. I have not worn high heels for a while, so I'm okay with that.
Perfect.
Not that there's anything wrong with wearing high heels, regardless.
Great recommendations.
Right.
And one final question. When it comes to postural distortion patterns past the age of infancy, so 6, 7, 8 years of age, and we start to develop more postural habits, we talk a lot at the American Posture Institute about postural hyperkyphosis, so having kind of that C-shaped spinal curvature. How does this impact dural tension?
Oh, so depending on the height of the person, I've been told that the decrease in the cervical curve and a kyphotic cervical curve can actually stretch the spinal cord, which is basically the dura, 5 to 7 centimeters. So that's huge, because the thing is, we used to think the dura was really flexible, and it's not as flexible. The dura has folds in it, and the folds let it open up like an accordion, right? And so if you keep stretching that accordion by decreasing that curve, you start to lose the leeway that you have. And the next thing that happens is that you get micro tears in it. And once you tear the dura, just like if you tear a ligament, because it's connective tissue, it ends up healing with scar tissue, becomes less flexible. So again, depending on the height of the child or the person, 5 to 7 centimeters of stretching of that dura can occur. Obviously, a 5-year-old is not going to be 6'2", but they're going to decrease the flexibility of the dural meningeal system and create more tension in it.
Wow. So impactful. Oh my gosh, we learned so much from you today. Everybody, again, just say thank you one more time for Dr. Rosen for so generously being with us on Peds Week and sharing with us such great clinical takeaways. Our goal Peds Week this year was to make it all about clinical application. Let us know in the chat if you have something that you can walk away with today and implement tomorrow in practice. Dr. Rosen, we want to acknowledge you and say thank you so much for the amazing work that you're doing and for your commitment to education, to teaching everybody out there the importance of pediatric care. We really appreciate you. Where can we learn more from you?
Thanks a lot. I appreciate it, Krista. So you can learn more from me as far as my professional website is drmartinrosen.com, and it has all our videos, books, and our seminars. Though this year we have not been able to teach too much outside because we can't travel. But yeah, drmartinrosen.com will have all our seminars because we plan to be back on the road next year. And we have, 20 videos, a couple of books and stuff like that. So we'd love to have you connect with us on that site and keep in touch. Thanks.
Beautiful. Well, thank you again so much. We really appreciate you and the amazing work that you're doing.
You too, Christopher. Thank you for putting this together. This is a lot of work. I know what kind of work this takes, so thanks.
Well, my pleasure. I get to learn from all of you too, all of our amazing speakers. So it's a brilliant opportunity. And to all of our viewers watching today, I just want to acknowledge you as well. Thank you so much for being here and taking your time out to learn more and stay cutting edge when it comes to pediatric postural correction care. Because truly, when we work together and help more children, we can make a tremendous impact on the world. And that's what this is all really about.